Ladies and gentlemen, please welcome Professor Mary Claire King, American Cancer Society, Professor, Departments of Medicine, Medical Genetics, and Genome Sciences, University of Washington School of Medicine, Seattle.
Thank you all very much. Having been seated here at this front table, I just want to say one thing in my role as free spirit. I will not be at all offended if anyone would like to leave and come back for dinner later, but if you do stay, please listen, don't chat. I want to tell you, I teach medical students, nothing phases me. And this is my native tongue. Je peux le faire en français si je dois, mais je préfère le faire en anglais, okay? So I wanted to use this 20 minutes in a way that I will never have the opportunity again. It's an extraordinary honor to be able to talk with people from a world very different than my own. I'm a geneticist working at a large state university. I love that life, and I hope to continue it for a very long time. To be able to talk to you, people who know how to take science and move it into the marketplace, offers me an opportunity to reflect on something that I proposed last year at the time of my Lasker Award that Mark just mentioned. And I want to propose this idea again, give it a little more detail, and have you think about it in your world. And this idea goes like this. I'll state the proposition first, so there's no foreshadowing, and then I'll back up and tell you what the rationale behind the proposition is, what the objections to it have been, what the enthusiasms about it have been, and then ask you to reflect on it given your perspectives on the world and how, if you agree with it, we might make it a reality, we might operationalize it. And the proposition is this, that every woman at about the age of 30 be offered, as a part of routine medical care, as routine as a pap smear, complete sequencing of the genes BRCA1 and BRCA2, so that if a mutation is identified that unequivocally destroys the function of that gene, she can be referred to an extremely high-risk follow-up program involving follow-up scrutiny and, based on the recommendation of the National Advisory Board responsible for this kind of analysis, referred for prophylactic removal of the ovaries and fallopian tubes before the age of 38 or 40 or so. I make this suggestion, I make this proposition on the basis of several lines of evidence that have accrued over the last 40 years that I've been working in this field, and they go like this. As Mark indicated, 20 years ago, BRCA1 and BRCA2 were cloned. These genes, they're sister genes, different chromosomes, both inherited in an autosomal dominant fashion. That is, they are inherited as often from fathers as from mothers. And they have the feature that their normal role is to be part of a large complex that's involved in DNA repair. So they're ubiquitously expressed, and they have a critical and fundamental role in biology of vertebrates generally. But when mutant, that is when the function of either of these genes is lost by virtue of a mutation that causes either a stop in the gene or the destruction of a critical element of its protein function, and when the other copy of that gene is lost by virtue of a tissue-specific mutation in a breast epithelial cell or an ovarian epithelial cell of a woman carrying an inherited mutation on her first allele. The consequence of that is the beginning of carcinogenic transformation and the development of a tumor either of the breast or ovary. In the first few years after the cloning of BRCA1 and BRCA2, there was a lot of dispute about what this risk really was. Partly the dispute was because not everyone knows how to do mathematics very well, but partly the dispute was because these risks really have become more serious over time in parallel with the increased risk of breast cancer in the population as a whole having nothing to do with inherited predisposition. So it's now quite clear that among women who carry an inherited mutation in BRCA1, the risk of developing either breast or ovarian cancer by the age of 70 is 70%, and by the age of 80 is 80%. For women carrying a mutation, an inherited loss of function mutation in BRCA2, the risk is slightly lower, but rising fast. In Israel, where a great deal of very good work on these genes has been carried out, the risk for women who carry mutations in BRCA1 is the same as in America. And the risk to women who carry mutations in BRCA2 is a little lower, but rising so quickly that from decade to decade, we can track its increase. So these are, please do leave if you don't want to hear. It's just fine with me. So these genes need to be taken seriously. And heretofore, it has been possible to sequence these genes in women who come from families that are severely affected with these diseases. And this is now very widely used in clinical practice in the best centers, certainly in this town. It's not universally used, even for families that are severely affected with breast or ovarian cancer, because it's a private service, and until very recently was a very expensive private service. The cost of this testing now, in consequence of rapid developments of technology, as well as the abrogation of the patent in 2013 on genes as products of nature, has now really dramatically widened the availability of sequencing so that both of these genes, indeed along with other sister genes, can now be sequenced and are now sequenced and information given in the context of genetic counseling and an appropriate referral for $250 rather than $4,000. That's what technology can do for one in the space of just a few years. We owe this to the success of the Human Genome Project and all of the technological advances that derive therefrom. So why do we need, in my view, to transfer this kind of offer from the individually decided doctor's office to just a general offering to all women? There are, I think, three reasons. The first I've already alluded to, and that is that mutations in these genes are inherited from fathers as often as from mothers. BRCA1 is on human chromosome 17, BRCA2 is on human chromosome 13. These are two different stories, but they are parallel. And one, of course, has a chromosome 17 from one's father and a chromosome 17 from one's mother, and it is equally likely that one will inherit a mutation from either parent. If one inherits a mutation from one's mother, it's very likely that that mother, if she lives long enough, will develop breast or ovarian cancer. The Angelina Jolie story, basically. Her mother, her maternal aunt, her maternal grandmother had all developed either breast or ovarian cancer. She knew she was at high risk and she took appropriate action. But for women who inherit these mutations from their fathers, there may very well be no one in the immediate family with breast or ovarian cancer. The father is very unlikely to develop breast cancer, obviously won't develop ovarian cancer. If he either had no sisters or his sister had the good luck of not inheriting the mutation from their parent, we may very well see no reflection of breast or ovarian cancer in the immediate family. So there's now very good data that if we confine the offer of genetic testing only to women who are from severely affected families, we will miss half the women who carry these critical mutations. But an important question is the risk actually the same for women who carry a mutation in the absence of a family history compared to women who carry a mutation and have the Angelina Jolie scenario. So to address this question, I carried out a study with my friends from Jerusalem, Efrat Levi-Lahad and her group at Shaare Zedek in Jerusalem. And we carried out this study in Israel because in the Ashkenazi Jewish population of Israel, there are really only 3 mutations, unlike the thousands that we see worldwide, that are responsible for inherited predisposition to breast and ovarian cancer due to BRCA1 or BRCA2. And the result of that study, in which we basically carried out a small but population-based study, was that women who are determined by genetic testing to carry a mutation in one of these genes, and then the mutation is followed through the family, have the same high risks of developing breast or ovarian cancer if they have no family history in their immediate family, as if they have the Angelina Jolie sort of scenario. It's the mutation, not the family history, that matters. So that's the first point. The second point is that there are an essentially infinite number of different mutations possible in these genes. I know these genes like I know my daughter. If you tell me a mutation and you say, oh, that woman has a deletion of 2 base pairs beginning at cDNA base pair 1000 of BRCA1, I'll tell you, Northern England near the Scots border on the western side of the country 400 years ago. I mean, each of these mutations has an origin in time and place, and we can find them. But appreciate that in order to make a stop in a DNA sequence, you can effectively do anything that will break the reading frame. You can delete 1 or 2 or 4 or 5 or 7 or 8, anything other than a multiple of 3 base pairs. You can insert anything other than a multiple of 3 base pairs, or you can make a direct nonsense mutation, so there are effectively an infinite number of mutations possible. If a woman walks in the door of my lab tomorrow that's never been tested for these BRCA1 or BRCA2, we sequence the genes, we find that she has a mutation, the chances are still pretty good 20 years in that it will be a mutation that's never been seen before. So the range of mutations that we need to look for is far larger than can be encompassed by any really simple 23andMe kind of approach. The FDA got it exactly right in saying to 23andMe, recreational genetics is one thing, but do not confound recreational genetics with giving medical advice on the basis of extraordinarily incomplete information. We actually need to be able to offer people the direct access to this kind of information. And the third reason is that in order to make a process natural, it needs to be available to everyone. There are all kinds of family dynamics that make it difficult in many families, regardless of where the family lives, for a person with a mutation to speak easily about that to other family members. If it's just a normal, everyday course of events based on one blood test that's taken when you're 30, it's not such a deal. Now, what would the yield be of such a test? What are we talking about? The answer is it depends. So, when I first proposed this last year, some colleagues, and I must tell you that as you would expect with such a proposition, the responses have been highly varied. And I've tried to, being originally a statistician, I've tried to find what are the correlates of what leads to a positive response versus a negative response. And I can tell you a couple of correlates. First, as you would expect, persons who have either had breast or ovarian cancer themselves and their relatives are far more likely to have a positive response. And people who are very, very close to actually treating patients, the surgeons, for example, are much more likely to have a positive response. And I am embarrassed to say it, but in my field, statistics, people are more likely to have a negative response. And one of these statisticians said, well, the yield of this test is going to be extremely small. Why is it worth doing? So I said, well, let's just think about that. So we have a test that costs $250. Are you with me? Stay or go. Okay, very good. All right. So for a woman of European Jewish ancestry, or any person of European Jewish ancestry, the chances of carrying such an allele are about 2.5%. There are 3 mutations. 2 of them have a prevalence in the Ashkenazi population of about 1% each, and one of them has a prevalence of about 0.5%. So that's 1 person in 40. 10% of breast cancer in the Ashkenazi population of Israel is attributable to to one of those 3 mutations. 40% of ovarian cancer is attributable to one of those 3 mutations. Since we've been working on this project in Israel for the last 20 years, the incidence of ovarian cancer has actually begun to decline. That's the kind of thing I would like to see here, and I see no reason that we shouldn't. What about the incidence, the prevalence of these mutations in our sort of mixed American population? We are, as our president says, most of us mutts. We have a little bit of everything in us. So we don't know, is the simple answer. We don't know what the actual prevalence of these mutations is, but bear with me for a little arithmetic. There's pretty good data based on old technology, so these are going to be low estimates, that about 5% of breast cancer in the American white and black populations generally, this has not been done for women of Asian ancestry in this country yet, but in the American white and black population generally, about 5% of breast cancer is due to one or another mutation of a very, very wide sort, those infinite number of mutations I mentioned, in BRCA1 or BRCA2. Fair enough. I already told you that in Israel and in the Ashkenazi population of New York, which have been evaluated very carefully, that the comparable figure is 10%. So if the arithmetic goes as follows for the Jewish population, we're going to make an analogous comparison for the non-Jewish population. In the Jewish population, we know that 10% of breast cancer is attributable to BRCA1 or BRCA2, and we know from direct data, good data, multiple studies in both countries, that the overall mutation prevalence of these 3 mutations in the 2 genes is 2.5%. If in the American population as a whole, the proportion of breast cancer due to mutations in these genes is 5%, it stands to reason that the total frequency of all alleles combined, of all mutations combined in both genes, is probably a little bit more than 1%. So if we were to offer testing to every woman at the age of 30, we would expect roughly 1 in 100 to carry a mutation in one of these genes. We could save the lives of those women. So why aren't we just doing this? There's one other substantial objection. The first one is cost. The second is I think that people really don't understand how frequently we will encounter these mutations. But the substantive objection is, what about mutations in these genes that we are not sure what they do? And my response to that is, you only report what you know. And this is where your field is so terribly important. You do not put a drug on the market until it's been vetted 6 ways from Sunday. You just don't do it. We don't offer results of genetic testing, or we should not offer results of genetic testing to our patients, to our customers is the wrong word in this case, to our participants, unless we know that they have an effect. None of this maybe stuff. We report back only mutations that, without a doubt, make a difference to a person's risk. It doesn't mean that we know every such mutation now. What I've talked about is sequencing BRCA1 and BRCA2. There are at least 20 other genes that also can undergo mutation and can increase a woman's risk of breast and ovarian cancer. Those can be folded in for women who are from high-risk families and don't carry mutations in BRCA1 or 2. But I'd like to start with 2 genes we know best. We also don't know anything about mutations that occur outside the immediate regions of the genes themselves. That awaits really whole genome sequencing and our understanding of the regulatory regions that bear on these genes, about which we're learning a tremendous amount, but we aren't in a position to know that yet. Another year or so, a couple of years, we'll know much more. So what I would like to suggest is we should get off the dime on this. We should actually do it. We should make a provision that every woman at about age 30 is offered. It's only an offer. She can say no. She can change her mind. It's what we do. Is offered testing for BRCA1 and BRCA2, complete sequencing in the context of genetic counseling, and if she has a mutation that is a slam dunk, no doubt about it, unequivocal, unambiguously damaging mutation in one of these genes, that she is referred for follow-up to a high-risk clinic, the sort that already exists in every major medical center, and that she is in fact followed for these mutations, and action is taken to help her think about surgery of the ovaries and fallopian tubes before she's 40 or so. We can save a lot of women this way. It's a straightforward thing to do. The technology is in place. I'm not a marketer, but it's something that I think we should be able to offer to people in the consumer space in a way that will help us move forward with this disease and save a lot of lives. Thanks very much.